Good afternoon, everybody. Welcome to this afternoon episode of Pursue General Pathology. And today we are with Pursue 5M, and we are streaming live from Kolkata. And with us we have Dr. Major Palash Kumar Mandal, who is an Associate Professor Pathology in Sagore Dutta Medical College, Kolkata, and Lab Director of Desun Hospital and Heart Institute, Kolkata. And he will be continuing from in the hemodynamic disorders. And today I think he'll be taking edema and the rest of it. So before I ask Dr. Major Mandal to take over, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With that, let me request Dr. Mandal, sir, please take over and share your screen and start the program. Thank you so much.
Thank you, sir. Good afternoon, everybody.
Yeah, your screen is yet to come. Yeah, please share your screen. Yeah, please make it full screen. Yeah. Yeah, thank you. Please start. Thank you so much.
Okay, sir. Good afternoon, everybody. So, today, as you know, we will come to the end of this hemodynamic disorders with this topic, that is edema and shock. All the topics we have covered so far in hemodynamic disorders are interrelated. So, if you have to study one, you have to recall the other also. So, with that, I begin my topic today. There is always a hitch in the beginning. I don't know why.
Yeah, I think so. I think it gets sorted out. Is it not moving?
No, sir, it's not moving.
I think you just need to log off and log in again.
No, sir, I think it will, because in the past also it has happened like that.
Okay.
And there is an echo in the voice, sir.
No, it won't be there anymore. I mean, that is it there now?
No, sir.
Yeah, that was because of conflict of various instruments.
Okay. I think it has.
Yeah, there it is. Thank you.
So, today's learning objectives will be the edema, where we will discuss the definition, the types, the causes, the pathogenesis of the different types of edema, the pulmonary edema, the renal edema, cardiac edema, cerebral edema, and hepatic edema. We will discuss the difference between the transudate and exudate. And in shock, we will learn the definition, the types, the pathogenesis of particularly septic shock, hypovolemic shock, clinical features of shock, stages, complications, diagnosis, and a bit of management. So we proceed with the first heading, that is edema. In Greek, it means swelling. The definition, please remember the definition I have told you also, my students, I keep on telling them, please write down all the definitions in first few pages or any few pages of your notebook. You can refer them easily before the examination, especially the viva or the theory examination. So that we define edema as an abnormal and excessive accumulation of free fluid in the interstitial tissue spaces and serous cavities. This is the definition, book definition. And what are the types? Basically, three different types of edema is there, under which further subclassification exists. First is the generalized edema known as anasarca. Second one is the localized edema, and Third one is the special edema, which is only related to edema in some special organs like lung and brain. Now, this is the clinical picture showing the difference between a pitting edema and a non-pitting edema. You have to understand, once you start going to the wards, you start your clinics, you have to understand these basic differences, because then only you can home on to the diagnosis, and unless you know the clinical examination properly, you will not be able to come to a diagnosis also. So all the edema may look like a swelling to your eyes, but unless you physically examine the patient and see the minor details, you will not be able to reach a proper diagnosis. Edema, pitting edema is most commonly seen in disorders with cardiac disease, disorders with hepatic disease, disorders with renal disease. Okay, so lungs, not lungs, there is liver, heart, and kidney. Derangements of these three organs lead to mainly generalized edema, and that is of a pitting type. Non-pitting type is with specific diseases like either filariasis or myxedema. Okay. Now, pathogenesis of edema. Whenever we discuss the pathogenesis, we have to go back to the theory of fluid movement. Fluid movement depends on the balance between the hydrostatic and the osmotic pressures, and that is the driving force, and that is the crux of Starling hypothesis, and which says that fluid movement between vessels and the spaces, here by spaces here we mean the interstitial spaces, which is determined by the valence of the hydrostatic and osmotic forces acting upon it. So what are the these pressures, various pressures which are there? At the arteriolar end we have hydrostatic pressure and we have plasma oncotic pressure. So the difference is 7. So this 32 minus 25 becomes 7, and hydrostatic pressure, you remember hydrostatic pressure, you can go back to your physiology, go back to your physics. So this hydrostatic pressure basically throws out, so it will throw out water. So whatever movement we are discussing is of the fluid, not the solute. Okay, it is the solvent or the fluid. So hydrostatic pressure, if it is increased, it will push water outside. Plasma oncotic pressure, which is dependent on the solutes, predominantly the plasma proteins and other proteinaceous substances. So those substances, that includes plasma glucose and other substances also. So those substances, if they are increased, especially plasma protein, if it is increased, the plasma oncotic pressure will be raised. In that case, it will draw fluid inside. Okay, so that is the concept, that if the hydrostatic is more, it will push water outside. If the oncotic pressure is more, it will drag water inside. Okay, attract water. You have done experiments of this osmosis with a potato, with the eggshell. So these have, I think you have read up or you have done it yourself in your biology textbooks or classes. So those are based on the same principle. Okay, so there is a oncotic pressure, there is a hydrostatic pressure. One is the driving force of going out, and one is the driving force of bringing in. At the venular end, the system, the pressure variation changes. So hydrostatic pressure becomes low and the plasma oncotic pressure becomes more. So at the venular end, the fluid will come inside. At the arteriolar end, fluid will go outside. So based on this principle only, all the fluid exchange, the nutritious substances, the gases, everything, they revolve around this particular physiology. Okay, so you have to understand it quite well. Now coming to the pathogenesis proper of edema, what happens is that whenever there is reduced plasma oncotic pressure, that the protein level goes down below 5 gram per deciliter, there is increased in capillary hydrostatic pressure, or in cases where there is lymphatic obstruction which leads to the lymphatic outflow of the local area, there is edema. Okay, so the first two is we have understood before also. So reduced plasma protein, when does it happen? When there is increased excretion of plasma protein in kidney diseases, in glomerulonephritis, nephrotic syndrome. These are the diseases where there is more amount of plasma protein which is excreted out of the system. Okay, liver diseases, the protein is synthesized in liver. So if the liver is failed, there is liver failure. So in that case, the plasma protein are reduced due to low synthesis. In kidney diseases, it is due to more excretion. In liver disease, it is due to less production. Okay. Capillary hydrostatic pressure may be increased in cases of heart failure, congestive heart failure, where the heart is unable to pump out the blood. There is congestion. So there increased capillary hydrostatic pressure because the blood is accumulating in a particular space. Okay. Similarly, in portal, increased portal hypertension. So due to liver failure, there is portal hypertension. So portal pressure is increased, raised. Obstruction, there is a localized obstruction leading to stagnation of a flow. Stagnation of flow, it is the venous flow, this lymphatic flow, and it leads to, indirectly it leads to increased hydrostatic pressure. Increased capillary permeability. So this capillary permeability leads to reduction of the fluid level. Okay, so reduction of the fluid level, but capillary permeability also does lot of other things. There is not only reduction of the fluid level, there is proteins also, they try to go out of the particular vessel and go into the interstitial space. So at the end of increased capillary permeability, as we had discussed in acute inflammation, I think you remember acute inflammation. So there is a protein rich exudate which is formed in the interstitial space or the space where we have a swelling. That swelling was known as tumor. Okay, remember tumor, dollar, calor. Okay, so that was the tumor, and that was formed due to a protein rich exudate. Okay, now tissue factors, they also are important. Here by tissue factor we don't mean the coagulation tissue factor, it is the tissues, the factor related to the particular tissue. That is, if there is loose stroma, there will be more accumulation, like in scrotum. Okay, the area which is more dependent, that will have more accumulation, because the leg, we are always standing when we are mobile, so the fluid tries to accumulate by the gravitational force in the feet. Okay, so that is the basis of this tissue factor. The most important of this is this, you have to understand, I have made it in bold letters, sodium and water retention. Eventually everything depends on this particular cycle. You have to remember it very well, understand it very well. So everything is revolved around this sodium and water retention. Eventually there is sodium and water retention, and this retention leads to the swelling of that particular area and the dependent area, whether it be feet, whether it be the sacral region. That is another region where we examine pitting edema, because the person who is supine, who is sleeping, because the person is unable to get up. Okay, bedridden patients, there we see the edema in the base of the sacrum or the sacral area. Okay, that's the backside. So because that person is not mobile, so that gravitational force and the edema collection in the foot, that doesn't happen in those patients. Okay, coming to water and sodium and water retention, the basis is that whenever there is renal ischemia, ischemia means reduced blood supply, so there is renin is secreted. Renin is type of a hormone which is secreted from the juxtaglomerular apparatus, and it leads to production of angiotensin, which is another globulin. This angiotensin is converted to angiotensinogen. Sorry, angiotensinogen is converted to angiotensin by angiotensin 1, and angiotensin 1 by angiotensin converting enzyme is converted to angiotensin 2 in kidney and lung. Okay, and this angiotensin 2 leads to secretion of aldosterone from the adrenal, and adrenal leads to secretion of antidiuretic hormone. So antidiuretic hormone or ADH is secreted from the pituitary. So this antidiuretic hormone leads to conservation of water. Antidiuresis. Diuresis means more more water release. Diuresis, that is, the person releases more water through basically through urination. That is called diuresis. So antidiuresis means the reverse of that. So the water is conserved, preserved. That is, there is less urination. So less urination, where will the water go? It will go into the interstitial tissue spaces. Okay, so this is very important. Renal ischemia, renin secretion, angiotensin activation, and that angiotensin activating aldosterone, and eventually ADH is secreted. So this whole system, please remember very carefully. Everywhere this will come into picture. Now renal edema. We are discussing the different types. So we discussed the pathogenesis of edema in general, but now we will discuss the individual component of this edema. First is the renal edema. Mostly it occurs in cases of nephrotic syndrome and nephritic syndrome. As I told you, the reason: reduced plasma protein, reduced plasma oncotic pressure. Pulmonary edema due to capillary hydrostatic pressure is normally about 10 milligram, 10 mmHg, millimeter of mercury. However, if the capillary pulmonary hydrostatic pressure is increased due to left ventricular failure, thyrotoxicosis, there is pulmonary interstitial edema, and which leads to also alveolar edema. First, there is interstitial edema. Interstitium is the space between two alveoli, small space. But once the interstitium is filled up with water, that water spills over into the alveolus, and the alveoli become waterlogged. Okay, so they are filled up with the fluid, and eventually there is respiratory distress, and if that progresses, there may be respiratory the oxygen saturation will fall, and the patient may die also. Increased vascular permeability in cases of fulminant pulmonary and extrapulmonary infarction. Inhalation of this, not infarction, that is infection. Inhalation of toxic substances, and ARDS, adult respiratory distress syndrome, also known as hyaline membrane disease. So in those cases, there will be increased vascular permeability, and vascular permeability will lead to this interstitial edema and eventually alveolar edema. Okay, there is something known as acute high altitude edema. So this is high altitude pulmonary hypoxia. So this high altitude pulmonary edema, that is due to anoxic damage, anoxic capillary damage. There is hemorrhage, and eventually there is edema because there is this due to anoxia, there is low oxygen tension, and there is hemorrhage within the capillaries, and that eventually there is anoxia leads to renal ischemia. Okay, so we go back to this thing. There is anoxia, and eventually there is renal ischemia, and this circuit comes again into picture. But this is more in case of pulmonary edema because the pulmonary vessels are involved more. Okay, so anoxic damage or the pulmonary damage lead to more pulmonary edema, but eventually with the progression of a particular type of edema, there is generalized edema also comes into picture. Okay. Cardiac edema. Cardiac edema, what does it mean? It is a generalized edema due to cardiac cause. Okay. So basically due to hypovolemia, that is the volume is reduced. Why the volume is reduced? Because the heart is not able to pump out enough blood. Okay. So there is hypovolemia. So this hypovolemia due to cardiac failure, there is suppose there is a myocardial infarction. The myocardial infarction leads to low output heart failure. Okay, from the left ventricle, the blood is not enough, blood is not released. Okay, so that leads to hypovolemia, and eventually the renin is secreted because there is renal ischemia, and the same that this cycle comes into picture, sodium and water retention cycle. So everywhere I am telling you this particular thing, please remember very carefully. So heart failure leads to increased capillary venous pressure. This is right heart failure. What is leading to increased capillary venous pressure? So capillary hydrostatic pressure is increased. Third point is, in chronic hypoxia there is capillary endothelial injury, which also leads to edema. Okay, so as endothelial injury is happening, the water is coming out of the blood vessel and into the interstitium. Okay, because there is capillary permeability is increased due to endothelial injury, because endothelial cells guard the blood vessels and they do not lead to leakage of fluid from the blood vessel lumen. Next comes cerebral edema, vasogenic edema, that is in Virchow-Robin space around the blood vessel. There is a Virchow-Robin space in the cerebrum. Okay, so in cases where, when does it happen? Basically in case of when there is a injury due to, that is known as cerebral contusion. Contusion means there is a blunt injury, is called contusion. So there may be blunt injury, there may be infarct, vascular infarcts. So that leads to the cerebral, leads to the stagnation of blood, and then increased this venous pressure, increased hydrostatic pressure, and eventually edema. And also due to endothelial associated endothelial injury. Cytotoxic cause, that is the intact blood-brain barrier. When there is intact blood-brain barrier, so that may be compromised. Where it can be compromised? Where there is hypoxia, where there is metabolic disorder, where there is meningitis. Okay, so all this may be leading to the derangement of the blood-brain barrier, and the blood-brain barrier, if it is compromised, then there will be accumulation of fluid inside the brain. So that is leading to cerebral edema. Interstitial edema, interstitial cause, that is in the periventricular white matter in cases of non-communicating hydrocephalus. So that is basically the, whenever you see there is a, these are the ventricles, you remember the ventricles from anatomy and physiology. So we have the two lateral ventricles, third ventricle, fourth ventricle. These are the space through which our CSF or the cerebrospinal fluid circulates. Okay, this is the pathway. If it is there is some obstruction in any of the areas, especially at the level of third and fourth ventricle, so that leads to the dilatation of the lateral ventricles. That is upward dilatation. Whichever space is blocked, above that the space becomes gradually dilated because of the accumulation of the CSF, because CSF is continuously secreted. Okay, so the accumulation leads to a condition known as hydrocephalus. Okay, so that is, and that fluid spills over into the periventricular white matter and leads to cerebral edema. Hepatic edema, due to hypoproteinemia, low protein production, increased portal hypertension, failure of inactivation of aldosterone. secondary aldosteronism. See, aldosterone, it activates ADH. Okay, and aldosterone, after the action is over, it is to be inactivated by substances released from the liver. But if that aldosterone does not get inactivated, it will keep on stimulating ADH, and ADH will keep on accumulating water, and eventually with water sodium is also retained. Okay. Secondary stimulation of renin angiotensin, same axis. Nutritional edema, that is due to hypoproteinemia, that is protein energy malnutrition. Okay. Mixed edema due to deposition of mucopolysaccharides. We have come to the end of edema, and this transudate and exudate difference, I will again tell you. Exudate is basically a product of inflammation. We have read about it. So whenever there is inflammation, there is a protein rich exudate which is accumulated in the interstitial space, that is known as exudate. Transudate is basically filtration without the change of capillary permeability. Okay, I have used the short forms. You have, please, whenever you make a note, please write down the full form. So filtration without the change of capillary permeability, basically increased hydrostatic pressure. Increased hydrostatic pressure and also reduced osmotic pressure leads to this transudate formation. Whereas in exudate formation, there is increased vascular permeability due to some inflammatory component or neoplastic component. So the second point is that the cause is either inflammatory or neoplastic. Here we have the basic cause is non-inflammatory. Okay. Protein content is usually high, more than 2.5 gram per deciliter. Protein content is low, usually less than 1 gram per deciliter. Glucose is low in exudate. In transudate, glucose is same as that of plasma glucose level. Exudate, the pH is low, whereas in transudate, the pH is slightly on the higher side. Exudate, the lactate dehydrogenase enzyme is high, whereas transudate is low. The fluid is to serum LDH is more than 0.6 in exudate, whereas it is less than 0.6 in transudate. There are many cells, different types of cells may be found in exudate. If it is a bacterial infection, we will find more of neutrophils. If it is a viral infection or mycobacterial infection, we will find more of these lymphocytes. Okay, but in transudate, we will have a few lymphocytes only. Mostly it is due to infective cause like pneumonia, tuberculosis, peritonitis, malignancy, etc. And here 3 important organs: heart, kidney, liver. So failure of either of these organs leads to transudate formation, which is a pitting edema in clinical practice. Okay, I think I am clear. Please remember the difference between exudate and transudate, often asked in the Viva table. Shock, our second topic. In Dutch, it means jar. So, shock, how it is defined? It is a life-threatening clinical syndrome of cardiovascular collapse characterized by number 1, acute reduction of effective circulatory volume leading to hypotension and inadequate tissue perfusion. If it is uncompensated, it leads to death. So this is the full definition. Okay. So life-threatening clinical syndrome of cardiovascular collapse characterized by acute reduction of effective circulatory volume and inadequate tissue perfusion. So this is in nutshell. Now there are 2 types of shock. One is the primary shock and one is secondary shock. Primary shock is due to transient vasovagal attack. you see, whenever a person vasovagal attack is the vagus nerve is there, that is the 10th nerve. So if that nerve is stimulated, and that stimulation can be due to so many reasons, including this neurogenic or this reasons, that is the some stimulation due to some there is a, suppose a person is getting nauseated, vomiting is there, so that vagus nerve which runs through the upper GIT, so that is stimulated. The person, suppose a person receives some very shocking news, so then also the vagus nerve may be stimulated, and there is a transient vasovagal attack. So the person, at times what happens is that if standing person is standing, and there is reduced blood circulation in the brain, sudden loss of there is sudden hypotension to the brain, and that also leads to a condition known as vasovagal attack. So this vasovagal attack basically is the sudden reduction of venous return to the heart due to neurogenic vasodilatation or peripheral cooling. Okay, so please remember this vasovagal attack. I don't know, when we were MBBS students, the first year, many of the of our not many, a couple of students, I would say, they had vasovagal attack when they entered the anatomy dissection room for the first time. So that was there. So just seeing the dead body lying there, and while the dissection, the first scalpel was running through the body of that person. So mostly it happens with girls, even boys are affected. So we have seen this happening. I don't know, you may have the same experience as well. So that is vasovagal attack. It may happen due to pain, trauma, sorrow, and it lasts for a few minutes to a few seconds to a couple of minutes also. The best thing is to make the patient lie down, raise the foot end of the bed, or raise the foot, so that the blood can flow to the brain properly. Okay. Secondary shock, circulatory imbalance between oxygen supply and oxygen demand at the cellular level. We will come to it in details. So if they ask you what are the different types of shock, you can start with primary shock, secondary shock. You can give a classification like hypovolemic shock, cardiogenic shock, septic shock, and others. Or well, this is okay. So hypovolemic shock, we have the causes are due to acute hemorrhage, severe dehydration, burns, etc. So the blood volume or plasma volume is reduced. Okay, so you can understand from the names. Cardiogenic shock, acute myocardial infarction, cardiomyopathy, arrhythmias, pulmonary embolism, they all lead to cardiogenic shock. Septic shock, mostly infective in origin. Bacterial, gram-positive organisms like streptococci, pneumococci, gram-negative organisms, Proteus, Pseudomonas, E. coli, Klebsiella, even fungal and viral. So the dengue fever can cause septic shock to a different mechanism, of course, but even virus can cause shock. Others are anaphylactic type of shock in cases of type 1 hypersensitivity reactions. Traumatic shock, like in severe injury, basically various factors come into picture, including hypovolemic shock also. Neurogenic shock, like head injury, high spinal cord injury. Hypoadrenal shock, like high dose of steroids, secondary and adrenal insufficiency. Okay, so these are the various types of shock, and you have to formulate a system and remember the names. Okay, need not remember all the names, at least remember a couple of names. Shock, clinical features. Now you see, how will a patient present when the patient goes to shock? Okay, so person is come to the outdoor or emergency, patient does not come to outdoor, the patient will come to the emergency room. Okay, how will the patient look like? How will you diagnose that the patient is suffering from shock? Because it is very essential. If you cannot diagnose a person who is in shock, then you will lose the patient. So be very careful. With the patient will be lying down, the patient will have an anxious pale face, altered sensorium, cold clammy skin, very important. The skin will be cold, clammy means wet. Okay, feeble thready pulse, pulse is very feeble, thready. Shallow shying respiration means the respiration is shallow, means the respiration will be not deep respiration, like no deep respiration, it's very shallow, means very fast and shallow respiration, not deep breaths. Okay, tachypnea means increased respiratory rate. There will be reduction of the blood pressure and the temperature may be reduced in this cardiogenic shock, but in certain conditions like the septic shock, there may be fever, that is the temperature may be raised. And also if you monitor the urinary output, there will be oliguria, that is the urinary volume is reduced. Oliguria is defined as less than 500 ml of urine per 24 hours. So that may be there, but for that you have to wait for a considerable amount of time, or there may be anuria. The patient's relatives may tell that the patient has not passed urine for quite some time. So you may understand from these findings that the person is in shock. Now coming to the pathogenesis of shock, there are three important derangements. One is the reduction of effective circulatory volume due to actual loss of blood or due to reduced cardiac output. That leads to impaired tissue oxygenation and eventually cell injury, because you remember the chapter of cell injury. Whenever there is hypoxia, the cell becomes, there is injury, there is initially there is reversible cell injury, okay, and later on there is irreversible cell injury, and the irreversible cell injury here will be necrosis. Understand? So impaired tissue oxygenation, and that leads to some inflammatory mediators. Mostly the inflammatory mediators are in cases of septic shock, but inflammatory mediators may also be released due to reduced tissue oxygenation and cell injury in other shock also. Other cases like in hypovolemic shock of arising due to either renal cause or cardiogenic cause, hepatic cause, in those cases too inflammatory mediators will be released. So please remember this, because you have to have a very clear understanding. So you may think that inflammatory mediators will only be released in cases of septic shock because that is related directly to the inflammation. No, not that. So in all cases of cell injury, wherever there is impaired tissue oxygenation and leading to cell injury, that is either reversible or irreversible cell injury, there will be release of these mediators. The common mediators are tumor necrosis factor alpha, interleukin 1, interleukin 6, which are released by the monocytes, neutrophils, etc. Okay. Coming to the pathogenesis of septic shock. So septic shock occurs due to bacteria. You see, previously in most of the books it was written that gram-negative bacteria is the most common cause for septic shock. It holds today also, but however in the West it has been seen that gram-positive bacteria are causing more cases of septic shock, which was initially not thought of, like streptococci, pneumococci. These organisms also cause septic shock, that was initially not thought of, but now it is being proved that they are also important causes of septic shock. And I also told you virus, fungi, they may also lead to septic shock as well. So whenever the question comes as the pathogenesis of septic shock, You start with the name of the bacteria, go to fungus and virus, and then this is a chart which has been actually inspired from Robbins, but you can go back to Robbins. It is almost a similar chart with more diagrammatic representations. So this is I have handmade it, but the theme has been taken from Robbins only. So the pathogenesis begins with the recognition of microbial products. Microbial products means the antigens which are present in either the bacteria or the virus or the endotoxins from the gram-negative bacteria. That product has to be recognized. The product are known as, what are the product known as? They are known as pathogen associated molecular patterns. Pathogen associated molecular, they are known as their patterns, pathogen associated molecular patterns. So they are recognized. Their recognition is very important. They are recognized by something known as TLRs, toll-like receptors. So the toll-like receptors present in the macrophages, they recognize the microbial products. There are some other receptors also. The G coupled associated receptors are there and other receptors are there. So first is the recognition of the microbial product, which is going to cause the infection or which has caused or which has already caused the infection. Okay. Recognition. After the recognition, the system becomes activated. The system becomes activated. So that after that recognition, the body responds by activating these pathways. So first, the neutrophils and monocytes, they are stimulated. They lead to the release of these factors, that is the tumor necrosis factor, the interleukin 1, interferon gamma, interleukin 12 and other things. Okay. So these are important because that is the beginning of the shock by release of this inflammatory substances. So basically the septic shock is the pro-inflammatory state. Pro-inflammatory state, you have to understand this. This is the inflammatory state. You remember the first chapter of inflammation. So first chapter, the second chapter was inflammation. So inflammation is that there is activation of all the systems. The complement cascade is there, the coagulation cascade is there, and they are all interlinked. I have told you they are all interlinked. So here the cells, the inflammatory cells are first brought into picture because they are the first line of defense. That is, first is neutrophil comes, they are known as the microphages, then comes the monocytes and macrophages. Okay, and they release these cytokines. Then the complement system is also activated, which leads to activation and formation of C3A, C5A, C3B. Okay, factor 12 is also activated. Factor 12 activation leads to something known as procoagulant state. Procoagulant means there is propensity towards coagulum formation, that is intravascular coagulation formation or thrombosis formation, is that the procoagulant status is achieved. Okay, so in blood vessel only the formation of thrombus may happen. So that is the meaning of procoagulant state, and that is directly by factor 12 activation or indirectly through endothelial activation, which can happen by the microbial products, that is the PAMPs, the complements C3A or the inflammatory cytokines. They all lead to endothelial activation, which leads to a procoagulant state. That is that there is increased tissue factor, there is reduced TFPIs, procalcitonin, and TFPIs, tissue factor pathway inhibitor. Okay, and increased plasminogen activator inhibitor. Okay, that is antifibrinolytic. That is, once the fibrin is formed within the blood vessel due to any injury or anything, the fibrinolytic system, that is the plasminogen activator, comes into picture. So the plasminogen activator, if it comes, it lyses the fibrin and leads to again the free flow of blood in that region. Whereas there is a plasminogen activator inhibitor. So that inhibits the plasminogen activator and does not let the plasminogen activator to lyse the fibrin or break the fibrin which is formed within the blood vessel. Am I clear? So you have to understand that this is a procoagulant state that will lead to more thrombus or more clot formation and less fibrinolysis. The cytokines again are released by the endothelial cells or the macrophages, and reactive oxygen species. What are they? The interleukin 6, the interleukin 8, the nitrogen oxide, and that is the other ones, okay, the PAFs. So what are the most important factors? Most important factors are the procoagulant status, the antifibrinolytic status, and release of the cytokines and reactive oxygen species. Understand, the reactive oxygen species, what do they do? They lead to vasodilatation. You know, nitrogen oxide, that leads to vasodilatation and increased vascular permeability. This vascular permeability, in fact, is the harbinger of formation of edema. You know, edema is formed because increased vasodilatation and vascular permeability. That was once the free flow starts happening from the blood vessel, the plasma leaks out into that interstitial space, there is reduced cardiac output. Okay, there is reduced cardiac output, and one of the causes of this reduced cardiac output is the renal ischemia. Renal ischemia, and not only renal ischemia, multi-organ ischemia. Multi-organ ischemia, there is reduced blood supply, and reduced blood supply means reduced oxygen supply to all the vital organs, and that leads to multi-organ failure. Also, the inflammatory cytokines, they lead to secondary inflammation, that is interleukin 10 mediated inflammation, and the secondary inflammatory mediators lead to reduced immunity. Okay, these are the primary inflammatory mediators, and this is the secondary inflammatory mediators. This is the interleukin 10, which is actually anti-inflammatory in nature. Interleukin 10 is anti-inflammatory in nature, and it tries to overcome the inflammatory effect, and in fact this leads to reduction of the immunity. If the immunity is reduced, there is more chances of getting infected, that is known as secondary infection. Suppose a viral infection is leading to your shock, some other bacteria might attack and also compound the effect of shock. So that is called secondary infection. So reduced immunity leads to those type of things, and systemic effects will be, there is fever, there is a release of this inflammatory cytokines like CRPs, procalcitonins. Okay, so CRP is C-reactive protein, procalcitonin, and eventually there is myocardial contractility also reduces. The myocardium in fact becomes fatigued. So it is the reduction of the myocardial contractility, and also there is a hyperglycemic status due to the body is trying to fight the inflammation. There is lot of corticosteroids which are pumped into the system, and these all lead to hyperglycemic state and insulin resistance. Okay, and this insulin resistance is also important cause of multi-organ failure. Okay, and this procoagulant effect causes this particular thing known as DIC, disseminated intravascular coagulation. This I have told you before also, we will discuss it in a separate lecture. This disseminated intravascular coagulation, or the DIC, is due to the production of multiple thrombi within the vasculature, and eventually it leads to tissue ischemia, adrenal insufficiency, and also that leads to multi-organ failure. Okay, so this is in a nutshell the pathogenesis of septic shock. Please remember, go back, read up the book, whichever book you are reading. So I have given you in a nutshell, and please try whenever you write shock, please write a pictorial diagram. Please draw a pictorial diagram which will help the examiner to understand that you have understood it well, because it is a very complicated thing. Which one is activating which? If you keep on writing, it will be in pages. So if you just can draw this diagram, it will give the examiner an idea that you have understood the thing. Now, pathogenesis of hypovolemic shock. It is the hypovolemic means the volume of the blood or the circulatory volume is reduced, and mostly due to reduced cardiac output. Okay, so hypovolemic shock is due to reduced cardiac output and depends on the loss of plasma. Loss of plasma may be due to blood loss, may be due to dehydration. Dehydration, severe vomiting, they may also lead to hypovolemic shock. A person who is having a continuous uh, passage of stool, okay, in cases of gastroenteritis or this food poisoning, this vomiting, there is this diarrhea, both these combining to lead to hypovolemic shock. Okay, and the severity depends on the amount of fluid loss. It is not just blood loss, it is the fluid loss. The fluid, if it is lost more, that means that is, if it is less than 1000 ml of fluid is lost, that is compensated. 1000 to 1500 ml of fluid is lost, that is mild. 1500 to 2000 ml of fluid is lost, is moderate. And if it is more than 2000 ml of fluid is lost, rapid fluid is lost without supplementation, that becomes severe hypovolemic shock. And mostly in cases of like accidents, like road traffic accidents, where there is huge blood loss, there is a rapid blood loss, so that leads to severe hypovolemic shock. Now, coming to the stages of shock, we have three different stages of shock. One is the compensated stage, that is the initial or also known as reversible stage. Second is the progressive decompensated. Now, once the compensated stage goes, it leads to decompensation, means chances of coming back are gradually reduced. Progressive decompensation is going on. Irreversible. Once this state is reached, this chances of bringing back the patient very difficult. Okay, so that's why from the very beginning you have to be alert. You have to diagnose the disease properly and start the treatment immediately. So that is the crux. You have to understand it's an emergency situation. Shock can never delay. If you delay the treatment of shock, you will lose the patient. Pathogenesis of compensated state is the air. What we see, there is a widespread vasoconstriction. Initially, you see there is vasoconstriction. Body tries to conserve the loss. There is fluid conservation by the kidney, by secretion of ADH, antidiuresis. The body tries to conserve the fluid. The effects will be tachycardia, that is increased pulse rate, cold clammy skin because due to the diaphoresis, and mediator, the vasoconstriction leads to cool skin. Cool skin means the body, if there is a more blood supply, there is a warmth in the area. If there is less blood supply, because there is a vasoconstriction, that surface becomes cool. Okay, mediators, and cool is also due to increased perspiration also. So mediators, neural, humoral factors, baroreceptors, catecholamines, renin, angiotensin 2, aldosterone, ADH. Same renin, angiotensin, aldosterone. Okay. So this is the pathogenesis and these are the effects. Coming to the next stage, or the stage of progressive decompensation. Here there is the vital organs start getting affected. There is pulmonary hypoperfusion, reduced cardiac output, reduced urinary output, tissue ischemia, ischemia of the major organs, that is the kidney, the brain, okay, the lungs we have already told, the other organs, vital organs like intestine, okay. So all these lead to the, whenever there is hypoxia in the brain, that leads to mental confusion, hypoxia in the lungs, that leads to ARDS, respiratory distress syndrome, metabolic acidosis. So all these are gradually happening. Now, irreversible, this is the last stage, very serious, and the chances of bringing back become very, very bleak. Progressive vasodilatation. Initially, there was vasoconstriction. The body was trying to prevent the blood flow and fluid loss. Now, the body has given up. There is progressive vasodilatation. The vessels are all getting dilated, and the vasodilatation leads to falling of blood pressure. Okay, so whenever there is vasodilation, there is fall, the blood pressure falls, and the blood pressure if falls, there is less tissue perfusion. It leads to also increased vascular permeability. There is release of myocardial depression factors, hypercoagulability, procoagulant state. We have already discussed. Pulmonary hypoperfusion, same thing, leading to shock lung, that is adult respiratory distress syndrome, shock lung, acute tubular necrosis in the kidney, hypoxic encephalopathy, the brain is damaged, focal myocardial necrosis, hemorrhagic gastroenteropathy, I told you the intestine will be affected, liver we will have necrosis, adrenal hemorrhage and necrosis. So all the vital organs are affected, and eventually the patient goes into multi-organ failure, and multi-organ failure leads to death. Complications, adult respiratory distress and the same thing, so known as shock lung, disseminated intravascular coagulation, acute renal failure, multi-organ dysfunction, and death. Diagnosis of septic shock. It's a question from actually microbiology, but since we are these days talking of alignment and integration, though this topic should be covered by microbiology, I have just given a few inputs from our side also. So isolation of the microorganism has to be done, and 2 blood samples should be obtained from 2 different venipuncture sites, and the blood amount should be at least 10 ml. So be very careful, because if you take less amount of blood, the culture may be negative, and you have to pinpoint the site of infection, wherever if there is infection at all. If it is a case of septic shock, remember, so you have whether there is some sinusitis, otitis media, or any other abscess is there, so you have to treat the offending area first. Okay, clinical features, laboratory findings will help you. Diagnosis, in peripheral blood you will see these are all septic shock, leukocytosis or leukopenia, and microangiopathic changes. There is the blood RBCs are you will see that there is fragmentation of the RBCs. Okay, hemolytic anemia picture is there. Other changes may increase, you will see increased thrombin time, decreased fibrinogen levels, presence of D dimers. You see in this COVID infection also, we are seeing the increased amount of D dimers. Okay, so that is one of the identifying features that how the patient is responding to the disease. Metabolic and biochemical features, the pH will be low, there is metabolic acidosis, and there will be hyperbilirubinemia due to liver failure, increased aminotransferase, especially the SGPT levels will be high. I told you hyperglycemia is common, but even in certain cases hypoglycemia may be there. Azotemia, that is increased urea creatinine level in the blood, and hypocalcemia. oliguria, proteinuria, cast may be there, arterial blood gas, there is hypoxia. Chest X-ray, depending on the particular type, you may see normal or pneumonia, volume overload, diffuse infiltrates of ARDS, atelectasis. ECG may show some T wave abnormalities. Treatment, I am not going into it. You have to treat the source of infection. You have to give antimicrobial agents. Hemodynamic respiratory metabolic support has to be given, and elevation of the head end of blood. Head end of the actually it should be elevation of the foot end of bed, not head end. And nutritional supplementation. But if there is a ARDS, then the head end has to be elevated. Depending on the type of edema, you have to see what is the general support, nutritional supplement. All these are given, but basically our answer will end here. And this is treatment part is we don't usually write, but you can just name, if it is a long question, 1 or 2 or 3 points you can write. We have come to the end of the topic today, and if you have any questions or queries, you can write back. I will be happy to answer. And our next class on general pathology will be after coming 2 weeks will be off, and after that I will again resume classes with immunology. Thank you so much.
Thank you, Dr. Palash Mandal. Thank you so much. Excellent lecture. And indeed, it is very important for all of us to know the various types of edema and how the pathogenesis of shock, especially the septic shock. Although on the slides we may not see all this, but then in order to have a complete understanding of general pathology, it is very important to know all these, because particularly in intestinal pathology, shock can lead to a lot of changes which can be ischemic in nature, and we all should know exactly what is the pathogenesis of that. Thank you so much. Right, so we have a break for 2 weeks, and then we resume after 2 weeks. Thank you so much. God bless you. Thank you. Take care. Bye bye.